Good morning. First to an 11-year-old male with a left Weber B fibula fracture. He's placed into a short AO splint for comfort. Next is a 16-year-old male. He's right-hand dominant. He fell while playing football. He had this left distal radius fracture. He was closed reduced and placed into a sugar tongue splint. Next, we have a 26-year-old female. She was right-hand dominant. She fell while she was snowboarding and sustained this left distal radius fracture. This was her imaging at presentation. And then when she came to the at the outside hospital, when she came to the office, she was slightly more dorsally angulated and no reduction had been performed. And so we took her for left distal radius ORIF. Thank you.
Is there a reason you didn't try to reduce it? It was almost acceptable before anything was done.
Yeah, and so I sort of wrestled with even showing because I didn't have the image where it was a little bit more dorsally angulated when she came to the office a few days later. So where she wasn't reduced in wherever she was seen originally.
So why not try one reduction? Everything looked good except a slight amount of angulation.
Yeah, I think we wrestled between sort of just reduce and splinter and cast her and go from there. I think that the thinking was we had her in the operating room. We had discussed going forward with the procedure, and we certainly just wanted to make sure that she had a stably fixed wrist.
How many days after the injury was she seen in the office?
Yeah, so she was seen almost a week out from the injury in the office, and when we saw her in the operating room, I think she was 10. So we saw her like that same week in the office, and then later that week to the OR. Thanks.
Four. Good morning. First patient's a 12-year-old female, status post pedestrian struck with a right distal tib fib fracture. She was closed reduced, placed in a long leg cast bivalve. She got compartment checks, was doing well, and went home next day.
So we're going to ask if you split the soft roll or not.
Yeah, so I cracked the cast and like opened it, and thereby affecting the integrity of the soft roll. So I think it was an equivalent of cutting the soft roll.
So do you think this one is higher likelihood or less likelihood of getting compartment syndrome than that other one from last week?
Less likelihood.
Why?
It's more distal.
Yeah, that's probably one reason, right? So it's is there much muscle belly down there?
Yeah, not much muscle belly down there.
It can certainly still happen, right? It can still bleed up into the compartment, but.
Next is an 11-year-old male status post fall with it's like a Salter-Harris 4 distal radius fracture, gentle reduction, and sugar tongue split. Next is a 7-year-old male status post fall with this right type 3 supracondylar humerus fracture. He underwent elbow CRPP. On exam, he was neuro intact, closed. No issues, did well post-operatively. We watched him the day, and then he was sent home. Next is a 10-year-old female status post fall with the right both bone forearm fracture. Closed reduced, placed in the sugar tongue splint. Next is 10-year-old male status post fall with the left both bone forearm fracture. Closed reduced, placed in a sugar tongue splint.
Morning. First patient is a 34-year-old gentleman who fell and sustained this left distal radius fracture associated with a volar shear component and carpus subluxation. He was initially closed reduced by the on-call resident and placed into a sugar tongue splint and taken the following day for a distal radius open reduction internal fixation. The next patient is an 87-year-old male who fell from standing and sustained this left hip greater troch fracture associated with an inner troch extension. These were his initial films in the EG that just was read as a greater troch fracture. CT imaging just showing greater troch involvement. MRI was obtained within a few hours showing inner troch extension, and he was taken a few more hours later for a left hip intramedullary nailing. The next patient is a 98-year-old female who was found down at her nursing facility. She has a history of dementia. She is non-ambulatory and wheelchair bound. She has a history of CKD as well. She was found to have this right valgus impacted femoral neck fracture. The family, after a lengthy discussion, we opted for non-surgical management with just pain control and DVT prophylaxis. The next patient is a 53-year-old female who fell down a few stairs at home and sustained this left SU2 periprosthetic distal femur fracture. She was neurovascularly intact. She was taken a few hours later for a left femur retrograde IM nailing. She had the total knee done 4 years ago. The next patient is a 73-year-old gentleman who fell down some stairs at home and was found to have this T9 distracted vertebral body fracture. He was neurovascularly intact. He's a sick guy, history of CABG, end-stage renal disease on hemodialysis. He has active foot osteo, and he was also found to have UTI on admission with a altered mental status and bacteremia. MRI is not here. The MRI showed no involvement of the posterior ligamentous complex. We opted for TLSO management of his T9 vertebral body fracture.
Anna, what do you mean by a distracted vertebral body fracture?
So if you look at the T9 level, he, instead of being compressed, it's kind of like opened up, like wedged anteriorly versus compressed.
You're saying pure distraction injury?
Sorry, say that again.
Are you saying you're calling it a distraction injury? So it's just distraction, or is it?
Yeah, it looks like just a distraction injury.
What's the one thing on the CAT scan that concerns you?
Yeah, so the area where it is basically a segment of dish. So it's kind of this rigid area that has like a stress riser in it. So it's more concerning, which is why we got the MRI. I apologize that it's not showing up in here. But it did not show any posterior involvement of the bony or ligamentous complex.
Right. So with these, you got to really keep a close eye on these. You got to like get, if they're in the hospital, get like, CAT scan every, 4 to 7 days just to make sure nothing's displaced further, because those can become very unstable very quickly.
Right. Yeah, we talked a lot about this guy, and just because he's not a very good surgical candidate and he's pretty sick actively, surgery is not a good option, and obviously not surgery is also kind of difficult. But I think we just think that treating it non-surgically and just watching it closely would be better.
With these ankylosed type spines, what's another thing you have to be concerned about, especially in these people who are older and have other vascular and cardiac issues?
What are some other things on the CAT scan?
Well, what's another thing you have to be concerned about when these ankylosed patients develop a fracture? They're high risk of developing epidural hematomas. So if they're on anticoagulation already, you have to be very, very concerned. And number two is that when trauma calls you or medicine calls you about DVT prophylaxis, you got to do something. You got to try to use something that's not going to put him at risk, a high risk for hematoma, like subacute heparin or something like that.
Thank you.
So
Next
what do you put them on then? What's better?
SCDs work great.
So just that, so non-chemo prophylaxis is what you're saying.
Yeah, I mean, you use SCDs, you use subacute heparin. You know, I don't know if he has a filter or not, but you know, if they're very high risk, you haven't put a filter on them.
Next patient is an 86-year-old female who fell from standing and was found to have this right LC1 pelvis fracture. She was made protected weight bearing as tolerated with a walker and placed on DVT prophylaxis. Oh, here's the MRI. Sorry. That's it. Thank you.
Sorry, 1 second. Morning. First patient's a 14-year-old male who fell on a trampoline and had a left Salter-Harris two distal radius fracture. He was closed reduced and placed into a sugar tongue splint.
So what would you do with that kiddo if he showed up to the office like that? 7 days, 5 days after injury, just like that.
I think you're kind of in a gray area at that point, but I think that I'd probably try to reduce it at 5 days. If it was like over a week out, I'd probably just leave it.
Yeah, he's an interesting one, right? Because he's got probably about 2 years of growth remaining.
Yeah.
So some remodeling there. And then your concern if you reduce it late is what?
Injured the physis.
Right. And then what would happen in that case if you say you reduced it anatomically so you didn't have to worry about remodeling? And then
You get a physial bar there.
Right. And his distal ulna could keep growing, right?
Yeah.
And then on the flip side, right, if you left it there and let it remodel, he's probably on the borderline, right? He's 2 years of growth left. He's probably got a decent amount of growth remaining. I think it's a no-brainer for what you did here for the ER. I think they're more interesting when they show up from the urgent care in a black wrist brace, 5 days after injury.
Yeah. There's a 79-year-old female who slipped her arm off an armrest and sustained this right middle third clavicle fracture. She was found recently to have recurrence of her breast cancer with metastases to her right clavicle, spine, ribs, pelvis, and femurs. Luckily, this is her only pathologic fracture. She's going to be treated non-operatively in a sling.
How are our femurs looking?
They're actually not too bad. They're just like a few small lesions that are not at risk of pathologic fracture.
What classification scheme are we using now for pathologic fracture risk?
Score.
Morning. The first patient is 83-year-old female. Status was fall with left femur periprosthetic fracture, Vancouver BA. Vancouver B1, sorry. Patient was taken to the OR for left femur open reduction and internal fixation. Next patient is 95-year-old female, status was fall with left hip IT fracture. Patient was taken to the OR for left hip IMA. Thank you.
Morning. First patient is a 26-year-old male who fell skateboarding on a half pipe with a left trigeminal equivalent ankle fracture. He was initially close reduced, taken the following day for an ankle ORF. Next is a 57-year-old female, sustained a trip and fall with a bilateral ankle fracture, also left. Close reduced, taken the following day for an ankle ORF.
This is the previous one.
What?
The syndesmosis injury.
There was a small posterior mouthpiece and it was displaced initially. So we decided to put the syndesmosis screw across just for the posterior mouthpiece.
I think the fibula is perfectly aligned with the tibia on the injury film.
Yeah, but there is a posterior mouthpiece which would demonstrate that the PITFL will be off. So,
like a bone?
Yeah. Next is a 29-year-old male who's involved in a motorcycle collision. He was hit by a car wearing a red light. The traumatic low knee amputation and posterior Anderson 3A open distal femur fracture. He was taken emergently by the trauma team to the operating room. We did not have any pre-op x-rays. For completion of the BKA and IND of the distal femur, it was taken back 2 days later for a repeat washout and revision amputation ORF, or revision amputation and ORF for the distal femur.
Did you do anything for the BKA in terms of targeted muscle reinnervation or plastics? Were they involved?
So we didn't finalize the BKA. That's gonna be done tomorrow, since there was still quite a bit of necrotic tissue there, and we cleaned it up again for a second IND. The plan is to go back tomorrow for a final version of the BK, and then we've already talked to plastics about doing a TMR.
Do you know what you have to do for if you're gonna hand it off to plastics when you do your portion of the case? If they're gonna do targeted muscle,
we did
not
tag.
It's not the tagging. You have to leave them long because they flip it back, so you can't cut it where you normally would cut it for when you do another BKA.
Yeah, we did try to leave all the nerves as long as we possibly could.
Serge, is that the idea that they have to be as long as possible, or just is there a specific length?
It's not a specific length, but you just want to leave it long enough because it's easy to find. Plus, they literally flip it around and turn it back and try to find any branch, like a little motor branch to a muscle, and it can be. You don't know where they'll find that branch. Sometimes it's distal, sometimes they have to go much more proximally, and you just don't want to put that nerve on tension necessarily.
Morning. This patient's a 58-year-old male who had a fall from a ladder with a right pilon fracture. It was initially it was closed, it was splinted, and CT was obtained. He was taken about 10 days later for open reduction internal fixation. Next is a 79-year-old female who sustained a fall down several steps with a type 2 open ankle fracture. She had about a 5 centimeter laceration over the medial mal. She was initially reduced and taken after an irrigation in the emergency department and beginning of ANSEF. She was taken for an ankle open reduction internal fixation. That's it.
So was the mortise anatomic?
Is that an Anna, that's it, and we got more to come, or is that, that's it, that's it?
It was a that's it, but Dr. Kirschenbaum had a question from the audience. So
Go for it.
question was,
Was the articular surface anatomic or close to it?
yes. Initially or post-op or?
You did the CAT scan. It looked like it was pretty much
Yeah,
excellent.
yeah, yeah. So even based on this X-ray, it looks pretty good. Typically, we will hold off on getting a CAT scan until we X-fix it. This patient, it appeared to be pretty much well aligned, so there was no need for an X-fix. So we got a CAT scan before an X-fix, and he did not get an X-fix. He was taken 10 days later just for an ORIF.
Is this one that could heal without hardware?
I don't think so. I think that you would have to keep his ankle immobilized for, 8 or so weeks, 8 or 10 weeks. I mean, the goal is to, we're putting hardware in to allow him to move his ankle. And we know that, gentle range of motion of the ankle is the best thing for damaged cartilage. So in a patient like this, that's the goal. So that's why we would fix something like this, even though it looks anatomic on the CAT scan. And it's not totally anatomic. I mean, there is
Isn't he
some
in varus?
displacement.
Is he in varus alignment? I don't know, maybe your plain films will show it better, but I mean, his ankle looks
Yeah,
like he
yeah.
has
The
a lot of varus.
overall alignment is a little bit of varus. The articular surface, I think, is what Dr. Kirschbaum was
Yeah.
referring to, which looks okay. But I mean, on the sagittal, like, there's some step off. It's not perfect. So
Where does that piece of cortical bone come from that's stuck in the in that sagittal split? You guys pull that out, assuming?
yeah, we did pull it out. I'm not sure where it came from, but that was removed at the time of surgery.
I'm not sure how you could treat that conservatively without it falling back into that varus position. I don't think there's any option for non-operative treatment on that one.
All right, that's it.